Hi, this is Elliot Fishman, and welcome to Facebook Live. And I'm sorry I'm 14 minutes late. I was at a meeting. I can't tell you who I was with. If I told you, I'd have to kill you. And so I can't tell you what I was with, but it was a good meeting and just ran late. So I'm sorry. And I got lost driving back. So anyway, I'm here. So I'm speaking about IV contrast, and I'll speak about contrast in general. And I have to give a talk on contrast. So I do know, all of us know a lot about contrast, right? We all use contrast 50, 100 times a day, oral, IV, rectal, in the bladder. But I decided I would go back and read everything that's been written about contrast recently or in the last number of years and look at some of the basic principles and try to see what things I could recommend. So let me first a little bit talk about IV contrast. So at Hopkins, we use Visipake 320 or Omni 350. I always like not to have a whole bunch of different contrast agents like 350, 300, because it just makes it harder to adjust the protocols. I think 350 works very well. People have asked the questions. There are higher concentrations, 370 in the US or 400 in Europe. And there have been a few articles that make the point that you can inject with a higher concentrations a little bit less, not as fast, and perhaps get the same density or more. A few of the articles with 400, which is not available in the US, made the point that 400 actually was too dense, that in coronaries, it would actually hide things because it was just too dense. So you don't want anything that's too dense either. From a safety perspective, one can argue which one is better, but the 350 works very nice. There's certain things to realize. So one thing that always comes up, and I always joke about it at the course, is warming contrast. So the reason we have warmers, and at Hopkins we have warmers, and if I go back 10 years, everybody had warmers, but then the warmers broke, or the issue with warmers became that JCO became very strict, that if you kept something in a warmer, you needed to keep track of the temperature and make sure the temperature didn't vary. So it became a whole extra step. But, you know, and then there was an issue. Some people said they were cited by JCO when they had the warmers. And the issue was, and you may remember if you've been a CTisus fan for a number of years, I called up JCO and I spoke with the head of JCO. She was very nice. And my question was, hey, someone told me there's a problem with the labeling of contrast you put in the warmer. What's the issue? And she was very clear and she made the point. She said, look, here's what we want you to do. When you put contrast in the warmer, and today is whatever today is, the 22nd of January, don't put down January 22nd. Put down February 22nd. Contrast is good for 30 days roughly. So basically what they wanted was for you to put down contrast labeling like it was milk. You know, in the refrigerator, you buy milk, and I don't know how they know when the cow's going to spoil, but you buy milk and it says a date on there, and then you shouldn't use the milk after that. Though we know it works, the milk works for a few days, but then it spoils at some point. The same thing with contrast. So if you're a tech and you pull contrast out of the warmer, you look at the contrast today and it says December 21st on it, then you know you can't use it. It says February 7th, obviously you can use it. So they said, just look, just put contrast in the warmer with the expiration date, not the date you inserted it. Because the concern would be is it's kind of like your house. If something gets pushed to the back of the refrigerator, you never get to it. And when you get to it, it's spoiled or it's growing like 27 types of mold. My refrigerator can cure a lot of diseases. There's a whole bunch of stuff in there. I don't eat anything at home anyway, but I don't know. There's a whole bunch of stuff in the back there. God knows what it is, but it kind of looks funny colors. So they don't want that to happen. So that's being very practical, and that's a good thing. Now, what is this thing with the warmers? Now, the one thing I read, there was an article from Duke a number of years ago that when you do fast injection rates, with you use warm contrast, 37 degrees, which is basically body temperature, 37 degrees, then the rate of extravasation was 1/3. Well, that's critical. We inject fast. Anything that would prevent extravasation, and it's simply as sticking it in the warmer, is something you want to do. There's a couple of articles. So I'm just looking to my left because I was reading some of the articles. There's an article by Bin Zin a couple of years ago. Says extrinsic warming to 37 degrees reduce allergic-like reactions to contrast, which are low osmolar contrast agents. The results of the present study were clinically significant and were in accordance with the latest contrast media guidelines. Moreover, contrast media guidelines promote a practical way of administering medication to help alleviate patient burden. So, oh my God, if you warm up the contrast, there's less reactions. That is really good. And I have to admit, I've always said that. I notice when you warm up contrast, even the quote unquote mild reactions, which are, feeling warm, feel like you have to urinate, all those funny things that people complain about, which kind of pass, but you don't get them. So it's very important. This article and a few others I read made some recommendations. You should always warm contrast when you're injecting high rates, 5 or greater. Injections of viscous low osmolar contrast media with concentrations above 300, which is what we use, and intravenously injected arterial studies in which timing and peak enhancement are critical, so typical CTAs. Now, I do like this, you see, because it's a very, very practical aspect of things, right? So we're saying that you need to do things correctly, so that becomes very, very practical, right? And the question would be is, why would you not warm? It's not like someone's going to say, well, if you warm it up, you're going to have more bad things happen. You're always going to only have things to your advantage. Also, you have the warmers, it's, where everything is. It's efficient. You got to warm the contrast, and you got to buy a warmer. Now, if I had a little bit more time, I would make a warmer. If Dan Peters was around still, we'd make a warmer, and you have it electronically to your iPhone, so if the temperature varied, you get a beep on your iPhone. And this also would calculate all of the numbers. You wouldn't have to go in and look at the temperature every day. That would be very, very good. Okay, now what else? We always talk about delayed contrast reactions. It's very interesting. We worry about contrast reactions immediately, which can be very severe, or in the first 15 to 30 minutes. And I remember people would call me up and say, well, I got a rash today and it's 3 days from contrast. I would say it must be something else you ate. None of us really thought about delayed contrast reactions. So what's the definition? An event occurring more than an hour to 1 week after contrast injection, but typically between 3 hours and 2 days. So that is perfect. I want to read that the way I'm looking to the left. The incidence is between like 0.5 and 14%. It's probably like 1 or 2% in our experience. Sometimes patients get a few hives, but we've had patients who had really bad rashes. Now, Visipeg's a wonderful contrast agent, but Visi gives you more frequency of rashes than, let's say, Omnipeg. So it's something to be aware of. And remember, most radiologists don't know about it because the patient's not here anymore. They're going to their family physicians or they go to the ER. But it's something to know about. And typically, it's treated with antihistamines and sometimes by steroids. Okay, it can happen. Now, if you say a patient had a delayed reaction, if they come back another time, is there a chance they're going to get a delayed reaction? It's a better than 25% recurrence because it's T-cell mediated hypersensitivity. So the best thing is to change contrast agents. That's all. Just change the contrast agent. That makes life very, very simple. Very, very simple. Another thing we've spoken about, or maybe I've thought about, is metformin. Remember the old days you had to get renal function, stop metformin for 48 hours, then get renal function, and then restart metformin? And metformin is a common agent. Well, we learned a couple of years ago that metformin does not increase the risk of contrast-induced nephropathy. And normally 90% of metformin is excreted unchanged by the kidney in 24 hours. The issue is some patients can develop metabolic acidosis, but contrast is not going to be an issue. And so patients who have above 30 GFRs, there really is no issue. You don't need to stop the metformin. You don't need to do anything, okay? With very low GFRs, it could be a risk factor, but just contrast is a risk factor in that regard. So metformin is not going to be a problem. So hopefully you've changed all your guidelines. I know that there was a thing in the ACR contrast guideline a couple of years ago, and that worked out very, very nicely in that regard. So Kieran asked a question during IV injection, why we choose the right hand. So first of all, the right hand decubital vein, right? You don't want to use the hand mainly. Well, I think the reason you do that is because it's a much more direct approach to the heart. It's easier to time because it's less travel. go straight up and then down into the SVC 123. From the left side, it's a longer travel and potentially the timing could be a little bit off. So it's easier to do timing when you use a right-sided injection. So that's the main reason. I once saw somebody early in the days of CT being filmed for a contrast injection. It was a live newscast, and they injected on the right side and they extravasated. So the person was really good. They said, okay, that injection was for the right side of your body. Now we're going to put another needle on the other side and we'll inject for the left side of the body. I thought that was brilliant. It beats saying, oh my God, I extravasated contrast. No, you just, left, right. May not be true, but it was a great idea. Okay, another thing that comes up, and there's an article coming out. It's actually in press in AJR, but you can see it. It's an article by Perry Pickard speaking about oral contrast. And I think Perry and I had this conversation. Maybe that's why he wrote the article. But the article reflects on the ER setting. What the heck do we do in the ER that people are not using any contrast, that maybe it's a negative? Now, it's interesting, and we agree with Perry that oral contrast, water can be very helpful, positive can be very helpful. Doing nothing is not very helpful. And I know without waiting 3 hours for the contrast to get down to the appendix, but just distending the stomach and proximal small bowel can be very, very helpful. You have abdominal pain, you're not distending the stomach. What are you reading in the stomach? Is undistended, can't evaluate, or you overcall, or you undercall. Also, pseudotumors in the small bowel. Is that a pancreatic mass? Is it not a pancreatic mass? You give oral, you give positive contrast, neutral contrast. You know what's to do on them. Even if you give it 5 minutes before, you have the duodenum, you have the stomach, you have the proximal bowel. We're not saying wait 3 weeks. We're saying just wait 5 minutes. Article by Alec Megabo. I went back, I forgot about this article by Alec Megabo. And, I posted this article on CTisus, I think just recently, and I made the point, never argue with Alec Megabo. But, Alex is a tremendous guy. Many of you know him from NYU, and Alex is one of the gods of CT. But he wrote an article a couple of years ago that he made the point that when they speak to the doctors at NYU, yes, sometimes oral contrast delays the study a little bit, but in his experience, the doctors are happy to have that delay because they're doing the study correctly. So that indeed becomes very, very important. It's a really good article by Alec Megabo. And Perry Pickard's article, which is coming out in, I think it's June, as I mentioned, he lists certain times when you always use positive contrast. He said, for example, and I'll just give you just his list: suspected postoperative bowel leak, suspected GI tract fistula, suspected interloop abscess or other fluid collection, oncologic staging and surveillance, nonspecific abdominal pain. And his point was very clearly, and I'm going to quote him on this, a disturbing recent trend, however, is the increasing decision to forego positive oral contrast material largely or solely for increased patient throughput, typically driven by non-radiologists such as emergency, ED physicians, surgeons, and even health system administrators. As radiologists, we need to ensure that financially driven non-medical justifications are in the best interest of our patients. And that is perfect. When you have some bozo administrator telling you how to do the studies because it might save 3 seconds and it probably doesn't, you don't want to be doing that. And we love our ER docs. ER docs are great at Hopkins, and I'm sure your place they're great as well. But in some places, the ER docs aren't so great. All they care about is turning the patients over. And the accuracy is not tied to it. Perry, the use of positive oral contrast material is a frequent protocol issue. Confusion abounds regarding its use. Even worse, many decisions are now being driven by non-radiologists for throughput gains rather than patient-specific considerations. The current indications for positive material are discussed, including areas of controversy. And I think it's a wonderful, wonderful article. And I like his conclusion. As radiologists, we need to ensure that such financially driven non-medical justifications are in the best interest of our patients. And that's a very good way of putting it. And it's very important to really, we need to have good throughput. I mean, the finances of medicine are very tough. And patients don't want to sit around the ER forever. We need to do things correctly. Correctly may be giving positive contrast. Even if it's a 15-minute protocol, get that whole stomach and small bowel. Look at your reports. What are you saying about the stomach? You're probably saying nothing. You need to be very, very careful. Very, very important. Really good article. It's in press, but if you go online, and Alec Megabo, this was a couple years ago, abdominal imaging. Our emergency physicians do not see that oral contrast administration for CT hampers operational efficiency. In fact, they have expressed gratitude to our Department for Care and Diagnosis. They have stated that delays in patients' turnaround are more frequently related to overall demand on the scanner and not to oral contrast consumption, period. They are acutely aware of the serious consequences of missed or incorrect diagnoses, which lead to inappropriate hospital admission or discharge, and will always choose good medical care over time-slashing, corner-cutting methods that impress the dashboard monitors, perhaps at the expense of excellence in patient care. And you cannot say it better than Alec. And those people in New York, they know. You know, in New York, Frank Sinatra said, if you can make it there, you can make it anywhere. So here, Alec Megabo again. In summary, the radiology department at NYU Langone Medical Center, I think they renamed it, maybe it's just Langone now, has, through dialogue with our emergency medicine section, reaffirmed the benefits of oral contrast for ED scanning of ED patients. We have found that stocking the oral contrast in the ED and allowing a 45-minute period for oral contrast administration, coordinated with obtaining clinical and lab information, facilitate radiology diagnosis with a high level of confidence and accuracy. It is, as stated by J.R.D. Tata, it is the insistence on relentless attention to detail and assistance on higher standards of quality and performance that are the keys to productivity and efficiency, most certainly not cutting corners. That is just brilliant, okay? And Alex is from New York. He eats a Second Avenue deli. Second Avenue deli, what do you think they do? They don't, you know, they ever seen the corned beef sandwiches? I mean, they can kill you, but they also make this heart attack sandwiches, potato latke, and corned beef. That could kill you. I never had one of those. It's a little scary. But the point is, they don't say, okay, we're going to put 2 slices of corned beef in there, we're going to call it a sandwich. No. The price may have gone up, but at least you get what you paid for. There isn't cutting corners. You need to be efficient. But I think there's a difference between efficiency and cutting corners. Cutting corners hurts the product. We don't sell corned beef sandwiches. We don't sell pizza. That's like selling pizza and not putting the cheese on and saying we're cutting corners. You're getting bread and you're getting tomato sauce. That's your pizza. I don't think so. I saw Larry David last night. That's what he said. With coffee, the coffee has to be hot. And now, if you watched the first episode last night, I'm not telling you to watch Larry David, but he put his nose in the coffee and his nose didn't burn. So I'm sure somewhere in the next 9 episodes, his nose is going to burn. But let's not worry about that right now. But I think this cutting corners thing is very, very important. So when you talk about contrast, when you talk about oral, and this month we're going to have a whole bunch of different word slides about oral contrast. Again, the thing is, people have written articles. They say, well, you don't need to give oral. You can just do nothing. But then the article says, but we never looked at the accuracy of the studies. Okay, well, you can close your eyes and say, I read the CT scan. But I'm not looking at the accuracy. That means I can say, okay, I can read scans with my eyes closed. And I just said normal. I'll be right sometimes. But you open your eyes. You're supposed to be looking at the scans. Okay? So I'm not being difficult, but I'm making the point that we need to do the right thing. Let me see. Clow has a question. I have 2 questions. People allergic to seafood, a previous allergic story, a reaction to contrast. What pre-medication do you use? Seafood alone, if they're allergic, most people are allergic to crabs or lobster. There's something in the crab, so that's not really an issue. When I worry, if you're allergic to strawberries, then you have a problem. That's when we see issues. But our pre-medication is 40 milligrams of prednisone, 24-12-2. In the ACR, they talk about 13-7-1. I like 24-12-2 because our allergy people say you need to really give 40 or 50 of prednisone at least 24 hours. If we don't give it long enough, then it's not going to work. But both are approved because the 13-7-1 is in the ACR, so you can follow that, and it is faster. And Brittany Johnson says, amen, patient turnover has become the driving force of clinical decisions. Radiology has to push back. I agree. I mean, we are on the same page. It's not pushing back. You need to do what's right by the patient. You need to be efficient. What you don't want to have is where if the doctor wants oral contrast and then goes to the pharmacy, and the pharmacy takes 4 hours to deliver things. That's when things break down. Now you have oral contrast, it's in pre-mixed things. We've talked about that. It should be sitting there in the CT area, it should be sitting in the nursing station. Then you give it to the patient, boom, boom, and they drink it right away. People are thirsty, the contrast tastes like water, you keep it chilled. Life is simple, but we need to do the right things by our patient. We talk about radiation dose. Oral contrast, IV contrast are critical because if the study's done poorly, you don't get the answer, then you repeat the study. Everything is protocol, and protocols are KV and MAS. And Image Wisely now, which I'm part of, is going to expand from just worrying about radiation dose to doing the right thing by the patient, be it IV, be it oral, be it gadolinium, whatever contrast. That's part of patient safety. And imaging wisely and imaging safely and imaging gently, it's all the same. Every part of the puzzle. If you have low radiation dose and it's too low, it's no good. If you have low radiation dose and bad injection of contrast, it's no good. If you have low radiation and you don't get the oral when you need it, that's no good. So we're talking about what is good for our patients. So we need to do the right thing. So it looks like I've been on here for 21 minutes. I'm not running for office. Let me just tell you that I am not running for office. And if nominated, I will not serve. I don't like it. I don't like living in Washington. So I'll take whatever I can. Anyway, I thought strawberry allergy was not related these days. I'm telling you, strawberries is big. It's the seafood. People in Baltimore eat a lot of crabs. There's something on crabs. They're kind of ugly looking things, and they put this powder on it. I don't know whatever they put on it. But people are allergic to this. Sometimes they throw up. But if you're allergic to those things, if you tell me you're allergic to tuna, I might worry. But if you're allergic to crabs and lobster and mussels and all those things that aren't kosher anyway, so I don't eat them, then it's not that. I don't worry about seafood. Sometimes you ask people you're allergic to abalone, shark, whale. Nah, probably not. Probably not going to matter. Anyway, we'll have some more stuff. I'll probably do a lecture on oral and IV contrast. We'll get you some more information. There'll be 1 million pearls when Lily can put them up in the February Pearl section of CTisus. And someday I'm going to even upgrade our app on contrast if I ever get to it. Another question, what do you prefer for coronary arteries? Good vein, 5 to 6 cc's a second. Visi or Omni both work equally well in my opinion. So Visi 320, Omni 350. And with that, I'm going to wish everybody a great day. And so some of you who may be chilly, I got my one of these jackets on. Look at that, Johns Hopkins radiology jacket. It's an old jacket. I found it on my floor, but it was cold in my office. So anyway, I wish everybody a great day, and hopefully this was helpful to you, and we'll see you around. Have a great day. Bye.